Thank you, Madeline. That was really a beautiful introduction, very sweet. And I think you should say that in a number of these initiatives, you have been a very substantial participant, including the CP case control study and the ELEGANT study follow-up. So thank you very much. Well, it's a pleasure to give a seminar to our department on what I've been doing for the last several months. And the first question I have to ask is, how does a perinatal epidemiologist get involved with convalescent plasma? So I have to provide a little background history as to how this all came about. And it starts in an odd place. It starts with something that we don't really have a title for, but I might just call it the Anti-Precision Medicine Project. So for some years, I have been concerned about the direction biomedical research, including epidemiology, has been taking, and especially its inordinate focus in some quarters on the human genome. And one day I read an op-ed in the New York Times, "Moonshot Medicine Will Let Us Down." And the author was Michael Joyner, an anesthesiologist at the Mayo Clinic. And Michael ended his piece with this: like most moonshot medical research initiatives, precision medicine is likely to fall short of expectations. We would be better off directing resources to better understanding what it takes to solve messy problems about how humans behave as individuals and in groups. Ultimately, we have more control over how much we exercise, eat, drink, and smoke than over our genomes. Now, I was so surprised to see someone who came from a totally different corner of the world, anesthesia, and he's actually a laboratory physiologist, student of exercise physiology, having similar concerns to mine. So I wrote him a fan letter, and we began to think about collaborating and identifying like-minded thinkers. A year later, a group of us met in Boston. In addition to the two of us, Michael and me, we were joined by Arturo Casadeval, who is chair of microbiology at Johns Hopkins, Greg Fink, our own faculty member in pharmacology, Sui Huang of the Institute for Systems Biology in Seattle, and we were hosted by two colleagues from Tufts, Carlos Sonnenschein and Ana Soto. Now, all of these academics are basically laboratory science people, and I found that they shared with me a concern that I thought was a little bit more of a public health concern. So we continued to interact in an email discussion forum. Ultimately, we have about 30 people from a wide variety of disciplines: medicine, laboratory science, social science, and we have two deans of public health involved with this group, Sandro Galea of BU and Sten Vermund of Yale. And we've written viewpoints and reviews, and ultimately we were invited to edit a special issue of Perspectives in Biology and Medicine. And in autumn 2018, we published this issue, 10 articles by different members of our groups addressing different aspects of precision medicine and its problems, edited by Mike and myself. I want to specify that the cover is courtesy of Mark Watrich, our own Mark. This lovely precision medicine bubble being about to be bursted on this notion of a target which is very precise, maybe not so accurate. Before I tell you how this morphed into that, I need to provide you some background on the notion of passive immunization, which is what convalescent plasma is a part of. I will explain in a moment how the Anti-Precision Medicine Group managed to get involved in convalescent plasma. But first, I need to tell you a little bit about the history of our attempts to create passive immunity in people. By passive immunization, we mean the transfer of preformed antibodies to a recipient to prevent or cure disease. It must be distinguished from active immunization, where we use vaccines to stimulate the immune system to produce its own antibodies and to have immunologic memory. Passive immunization provides only temporary protection, usually about a month or two. Now, there are three forms of passive immunization: hyperimmune globulin, convalescent plasma, and monoclonal antibodies. And I'm starting with the oldest first. And believe it or not, hyperimmune globulin is a technique that has actually been around for 130 years. So it began when two really amazing scientists in Germany, von Behring and Kitasato, discovered in the 1890s that if serum from rabbits who recovered from diphtheria and tetanus had something in their serum that could, if you inject it into a susceptible animal, could prevent or cure that same disease. And they finally were able to show that the active agent was an antitoxin, effective against the toxins created by these bacteria. And interestingly enough, Behring and colleagues mass-produced this antitoxin and provided it to treat people with the disease quite effectively, very effectively. It was one of the first really dramatic interventions of modern medicine in the 1890s. And Emil von Behring received the first Nobel Prize ever given in physiology and medicine in 1901. He established something called Behring-Werke, a company in Germany or possibly Austria in 1904. And eventually, after many incarnations, it merged with an Australian firm, Commonwealth Serum Laboratories, established in 1914 to form CSL Behring, which is still alive today and makes several immunoglobulins and coagulation factors. So immunoglobulins, which is the distillation of plasma from or serum from a recovered individual or animal to find that nub of antibodies, concentrate it, and give it by injection to people, has this long history. And apologies for that phone ringing, someone will answer it. Now today we have several hyperimmune, we call them hyperimmune because it's distilled from many, many people, many forms of antibody in it, or sometimes called polyclonal because there are multiple antibodies in this kind of a product. Here are the licensed products that we have now. They're often used for post-exposure to prophylax against the several forms of hepatitis, tetanus, RSV, vaccinia, any number of them. And a nice review paper in 2015 from the NIAID. The Graham there is the director of their vaccine study services. Now, right now, in fact, hyperimmune globulin is being actively created as a treatment, potential treatment in COVID-19. The plasma fractionating companies, which are the people who nowadays make these kinds of products, they take plasma from many donors and distill it down, and they manufacture an antibody product. They've agreed to merge resources and create a generic hyperimmune globulin derived from patients. So it's been claimed they were not trying to make a profit. They're going to give this at cost. A group is called the COVID Plasma Alliance, and a trial has just begun. The principal investigator is William Mezzanotte of CSL Behring, and this trial is supported by the Gates Foundation and NIH, but it's only just getting underway. Now to turn to the second form of creation of passive immunity, the one I'm going to talk about mostly today, convalescent plasma. Unlike the hyperimmune globulin, it's not a manufactured product, but it's just obtained acutely from a recovered patient for use in a sick patient, from one patient to another. Because you need no manufacturing, CP can be used nearly immediately in an epidemic situation. It takes months to create a hyperimmune globulin product. Even now, as I tell you, right, in the midst of this epidemic, we see this trial for the first product only just now beginning. There was a substantial history of success, we think. I mean, there weren't randomized trials done in the early 20th century in bacterial meningitis, in pneumococcal pneumonia especially, and in the 1918 influenza, there's data to suggest it was effective. Today, we obtain convalescent plasma by plasmapheresis, which returns the red cells to the donor, so people can even donate plasma as often as once a week for a while. And each donation can be as much as 600 cc's. Some people have given more even, and which could serve 3 patients if you take 200 cc's as a dose with sufficient antibodies. So it's a complex process because you have to find a donor who has antibody levels, we hope, or presume, and then get them to somebody, but it doesn't take a whole lot of time to get this going. Now, the third form of antibodies, which gets a lot of attention today, is the monoclonal antibodies. Yesterday, the New York Times had an article about monoclonal antibodies, and they said if monoclonal was the only form of antibody treatment. It's not. It's just one of 3 forms. But anyway, it's the most recently developed. 45 years ago, Kohler and Milstein wrote the first paper on this. They got the Nobel Prize for it in 1984. It's a laboratory technique that involves fusing an immortal cell line originally from a multiple myeloma patient with an antibody-producing white cell, so you have immortal production of a single clone of antibodies to one antigen. It's historically mostly been used in the last 30 or 40 years for cancer or immune disorders. There are actually, surprisingly, only 3 monoclonal antibodies approved for infections. One treats respiratory syncytial virus. The initial studies were a little bit iffy, so it's been restricted really to high-risk infants, severe prematurity, kids with congenital heart disease. Also for post-exposure prevention of anthrax, and now quite effectively for the treatment of Clostridium difficile infections, which, as you know, are very nasty GI infections. So compared to its usage for cancer and autoimmune disorders, the infectious use of monoclonals is quite small. Now, in COVID-19, as you probably heard, both Eli Lilly and Regeneron are both actively developing monoclonal antibody, and they're conducting human trials right now. Unfortunately, all we know of this, as of this date, is from news releases by the company. There's no published data. They just make statements in their news releases. Science by news release, not my favorite form of science. The audience is not so much scientists as the stock market, but anyway, that's what we have. And the Regeneron product is 2 antibodies. One is derived from a human mouse chimera, the other from recovered patients. They're both virus neutralizing and active against the spike protein of the COVID-19 virus. I haven't been able to find the details on the Lilly antibody composition. Outside of clinical trials, to my knowledge, each product has been used in just 1 patient. The Regeneron product was used in President Trump's illness, and the Lilly product in Governor Christie's. These are, nothing has been published on these products. They are, by the way, the monoclonals, there are 2 issues. One is, did you pick the right antibody? They're monoclonals, they're single clone. When you get convalescent plasma, you get multiple antibodies to many components of the viral particle. Same is true for hyperimmune globulin. Secondly, you get it in gram amounts as opposed to milligram amounts. Your dosage is massive. I find myself wondering if someone who got a massive dose of antibody early in the illness plus steroids, whether that person would produce antibodies of their own. Might be worth testing that person for antibodies to make sure they're immune after their illness. So now to return to our anti-PM group. So for many years, we had discussions about what we were against, but we often said to ourselves, what is it we are for? And then COVID hit. And suddenly, we found our cause. So a key paper that energized our group was by Arturo Casadevall, who, as I've mentioned before, was a early member, an early member of our convalescent, our anti-precision medicine group. And he, collaborating with his former colleague, used to be at Einstein, he's now at Hopkins, Lisa Ann-Porowski, wrote a nice paper, very nice paper, in the Journal of Clinical Investigation called The Convalescent Sera Option for Obtaining COVID-19. I won't get too much into the details of serum versus plasma, but in the early days, serum was used a lot. And now we use plasma, which contains the coagulation factors, which are often used when plasma is administered for other purposes. So Arturo and Lisa Ann argued that since we have no other treatments for COVID-19, it might be wise to consider convalescent plasma, a form of passive immunity that's been used successfully in the past. So why not use that now? And Arturo also wrote a very nice op-ed in the Wall Street Journal describing a little story from the 1930s where a school physician confronting what appeared to be an outbreak of measles, one child in a boarding school had measles, and he took blood from that sick child and injected it into the other students in the class, and not a single secondary case of measles took place. Measles, as you know, is a hugely communicable disease. So he used that for the lay point to kind of argue, to show to the public the value of this kind of an approach during an epidemic. And the point is, as I said before, during an epidemic, you don't have time to manufacture a complicated product. So all of a sudden, our group started to initiate what we came to call the National COVID-19 Convalescent Plasma Project. which we abbreviate as CCP19. And it really just kind of mushroomed in weeks. Suddenly, by just simply word of mouth, we suddenly had a national group of hundreds of physician scientists interested in this. We had some large-scale phone meetings. There was an evident need for communication, explanation, and since I was the guy who said we need communications, everybody looked at me and says, "Okay, you go make up a website." So I don't know anything about making up websites, but ultimately, by working with Amazon Web Services, who donated their time, and MSUIT, they put up a website, ccp19.org, in less than 48 hours. And maybe some of you have gone to the website. We have all sorts of information. We attempt to be just an information resource for people interested in convalescent plasma. We list all the trials that are going on. We try to get protocols. And we sometimes make statements, as we did in late August, our response to the emergency use authorization of convalescent plasma, which I'll talk about in a moment. We have a chat box. You can ask a question. We're currently revising the website because we've discovered that more than half of our questions are, what does my antibody test mean? People get antibody tests, they have no idea what it means. And actually, truth be told, often we don't know what it means, but we're really working hard. We've got an advisory committee of really smart antibody knowledgeable people to help us, and we're revamping it as we speak. Eventually, a leadership group emerged. The three of us in the anti-PM group, Michael, Arturo, and myself, began it. We brought in colleagues, largely in infectious diseases, Lisa Borovsky, who was co-author with Arturo on his paper in JCI, Shmuel Shoham, who is also an infectious disease physician at Hopkins, Jeff Henderson, who is also part of our anti-PM group, who's also an infectious disease physician. And we realized we needed someone who really knew transfusion medicine. And so Jeffrey brought in his colleague Brenda Grossman at Washington University, a really wonderful group of people to collaborate with. In the early hot days of April and May, we had a conference call every evening, 7 days a week at 9 p.m. Eastern, 8 p.m. Central. And gradually we've reduced it to now once a week. Tonight we'll have our Thursday evening call at 9 p.m. I hope that's not during the debate, but who cares? And then, just as we were getting organized, a major development took place which just changed the whole face of it. When on April 6th, the FDA announced its expanded access program for convalescent plasma. And the amazing thing about this is that it turned out to be a program that was conducted jointly with the Mayo Clinic. So let me go over some of the FDA developments in relation to convalescent plasma. And now I'll explain why this particular development was so important for us. So actually, the FDA this year has issued 3 different authorizations for the use of convalescent plasma. First of all, you must understand that it's viewed as an experimental biologic product. It cannot be used without authorization of the FDA legally. It has to be approved by the Division of Biologics of the FDA. On March 22nd, the FDA authorized the use of convalescent plasma for compassionate use on a case-by-case basis. You could write to the FDA, call the FDA, fill out a 4-page survey and say, patient X, I really want to give him convalescent plasma. I have some plasma, it matches his blood type. I want to give it. You fill out the form, and they tried to expedite it, just one person at a time. Also, interesting enough, that emphasized giving it to people who are kind of use compassionate use, end of life, someone who's about to die. This is the last place to use convalescent plasma, as had been known for decades, as we have aptly found as well since. So, but shortly thereafter, only a couple of weeks later, FDA authorized the expanded access program. They negotiated with the Mayo Clinic to be a site that would serve as a research study that would that if you wanted to give convalescent plasma outside of the emergency compassionate use one by one, you had to enroll your patient in this Mayo Clinic study. And the major purpose was to establish safety and maybe measures of effectiveness, although since it had no controls, it would not be so easy to show effectiveness. And Mayo Clinic agreed to coordinate the study. I'm not privy to the negotiations between the FDA and Mayo, but I do know one thing, that the same day of the negotiations and the discussions, the same day, the Mayo IRB approved this research registry. So I think being able to have an IRB that can jump right up and get the job done quickly was very powerful. And then the program came to an end last August 23rd, when the FDA announced its emergency use authorization, which means you didn't need the expanded access and the study didn't need to enroll patients. Now anyone could use convalescent plasma on any inpatient. The emergency use authorization is restricted to inpatients. So essentially what happened was because we worked very collaboratively with Mayo and Hopkins and all these groups together and a whole group of scientists, we suddenly were part of this single-arm observational study, no controls. It's only effectively a research registry that's conducted. The data was being held by the Mayo Clinic IRB and eventually, shortly thereafter, BARDA. I can't remember what those initials stand for, but this is a well-known government agency that supports research in vaccines and the like. Got a contract to Mayo with Mike Joyner as the PI. And it lasted, that period of time really was 139 days from April 6th to August 23rd, just under 20 weeks. You can go find its website, uscovidplasma.org. It's not active as it was until August 23rd. And they obtained detailed information, including clinical status, mortality, complications. And this is what shocked us, on nearly 85,000 patients treated with convalescent plasma from all 50 states. It was 49 states for a very, very long time. Nobody in Vermont, where I was staying the whole summer, had been treated. And finally, I saw 50 states, and I called up and I said, Vermont started to treat patients? They said, yes, we have one treated patient from the state of Vermont. Okay, Vermont does not have very much COVID, thank God. When this began, we thought we might have a few hundred, a few thousand. Nobody anticipated we'd get 85,000. And the Mayo IRB did some other things too. It also authorized obtaining data on all patients, both treated and untreated with CP, from hospitals participating, so we could design a study, which we designed at MSU, to compare outcomes in CP-treated and untreated patients. So working with, and then a second effort, a very important effort, working with 56 blood banks, we obtained remnant serum samples from transfused plasma and measured antibody levels to assess those antibody levels in relation to outcome. So it turns out there are several clusters of research efforts that are undertaken. I'm going to go over them with you. 3 of them were initiated here by MSU faculty and people working here. 3 were initiated by the Mayo Clinic, and the Hopkins and Einstein collaborators are doing randomized trials, as I'll show in a moment. So I'll first go over our own work that we initiated from MSU. But first, let me tell you who here is working with us. Faculty members, Chenji Lee in biostatistics and Matt Reeves have worked with us. I stole shamelessly from the ECHO project 2 wonderful people, Brianna Kornatowski and Tengfei Ma. Raed Highlight served as a graduate assistant with us in the summer. I should say we did receive some funds from Takeda, which is one of the fractionating companies, gave us a gift, and we were able to get a small subcontract from the BARDA contract to Mayo to do the study I'm going to tell you about in a moment. And then we, lacking resources, we do have students lacking financial resources. We can put students to work. Several, I hope, are on this, are attending this meeting. Several you will recognize the names from epidemiology: Belisha Barrett, Megan, Alyssa, Allison, and then Erica Leidy, a medical student, Sarah Campbell, an undergraduate, Rachel Thompson and Thomas Borowski from Grand Valley State, who were brought in by Allison from her work at Kent County Health Department, a student from the University of Michigan, Kathy Slawinski. Bikram Dillon joined us. He was a University of Florida student who was about to start his internship and did start his internship at Detroit Medical Center, very interested in antibodies. And this group of students were also very, very helpful this summer in contributing to the maintenance of our website. So let me talk about the first project, the Patient Trajectories Project. This was devised to obtain information on treated patients quickly by requesting very simple daily reports by email or text from treating physicians as to whether the patient was better, the same, or worse than the previous day, just compared to the previous day, and whether they were on a ventilator, an ICU, died, or was discharged that day. So this took under a minute to fill in, and pleasantly enough, we got a lot of docs to do it. The programming was done really quite cleverly by Amazon Web Services, and it was initially on our website, but as soon as the EAP developed, we said we better put this on the Mayo website so that the people registering their patients on the EAP could see this opportunity to give daily status reports. We scored it in ordinal fashion. Death we scored as -2, worse as -1, the same as 0, better +1, discharge alive +2. And we looked at cumulative scores over the days post-transfusion. We actually got 7,000 plus patients filled in, patients to be filled in this study, most of whom were discharged or died. And I should say, to give credit, this was patterned on work I had seen and heard presented by Patrick Lawther, a British epidemiologist who examined self-reported daily scores. How do you feel compared to yesterday? Better, worse, or the same, in a panel of patients with chronic obstructive lung disease. And he was able to show those scores correlated with specific air pollutants. I thought that was a marvelous use of simplicity to show an effect. If you look at the trajectories, the paper is almost complete. Teng Fei, our own Teng Fei, is first author along with Chad Wiggins, who's a postdoc at Mayo. You can see that overall in the top left corner, most patients steadily improve at least for the first week or so after receiving convalescent plasma. But depending on your baseline status, your improvement is very different. Now, let me caution by saying we can't say this is any different from controls who received nothing. But nonetheless, you see that moderate disease improves better than severe disease, and critical or end-stage disease does not improve with convalescent plasma, nor if you look at the panel F, people on ventilators do not improve with convalescent plasma. Older people, if you look at panel B, don't do so well. And these patterns we find replicated in other kinds of research about convalescent plasma. And this suggests to us which categories of patients are likely to benefit most from convalescent plasma. That paper is about ready to be submitted. The treatment control study, which was authorized by the Mayo Clinic, the initial design was Chenji Li and myself. Hospitals could forward data to Mayo on all their entire panel of COVID-19 patients, and the Mayo biostatisticians would match untreated controls to the treated patients on sex, age, race, hospital, respiratory severity, and we matched on the day corresponding to the day that the treated patient got their convalescent plasma. And in the second phase, after matching, we obtained more data on background risk factors on treated controls. As I say, this protocol was approved by the Mayo IRB, and it's interesting, many of our hospitals have really accepted, as they did for the EAP, the governance of the Mayo IRB over their work. Some have submitted to their own IRBs, but a lot have said, Mayo has approved it, we're good to go. We've received help from the MITRE Corporation developing protocols to work through EMR data that has to be used for this. Brianna Kornatowski is responsible for all communications with hospitals and keeps this project going. It's interesting that the design is now being replicated by several major hospital systems, including the VA system, including HCA, Hospital Corporation of America, which is perhaps the largest group of patients. And we talk to them, we consult and advise with them. We're still enrolling hospitals. We do see signs of efficacy compared to untreated controls in early treated patients, and that theme will come up again and again. But we're not ready to publish, and that work is still ongoing. Thanks to the help of Matt and and our students in the summer began to think about doing a meta-analysis of just what is mortality like in hospitalized patients in COVID-19, for the purpose of saying, if we could develop a kind of an adjusted model, if you have so much age, pre-existing disease, and so forth, could you make some statements about expected mortality? That would allow us to compare convalescent plasma patients. Are they doing better or the same or worse than expected? And Matt and Raed are really honchoing that one, and I look forward to seeing that draft manuscript pretty soon too. So those are the three studies that were initiated at MSU. Now let me turn to the studies that come out of Mayo, and we're all collaborating together but have been initiated. The first is the safety study. Now, people have been worried about safety with plasma, but it's important to recognize that plasma from a convalescent plasma patient isn't really very different from the convalescent plasma that is used every day in the US. Annually, there are 4 to 5 million units of either fresh frozen plasma or 24-hour plasma. Fresh frozen means they're frozen in the first 6 hours. If you freeze plasma in the first 6 hours, put it in the freezer, it's good to go for at least a year. And it's given for multiple indications in medicine, replacement of clotting factors. It's kind of a good for what ails you product, a little bit like red blood cells. It's also used for fluid resuscitation, volume loss, shock, and so forth. And the convalescent plasma, the only difference is it's the same plasma, but it's just taken from people who had COVID-19 and have been asymptomatic for at least 14 days. We don't think there's residual virus in plasma. There's no evidence of that. That would be a fear, but people have not been able to find that. We published 2 papers on safety, the first on 5,000. I'll give you the data from the paper on the first 20,000 in the EAP, published in Mayo Clinic Proceedings. The 2 feared complications are transfusion-related acute lung injury, 0.1%, 1 in 1,000. TACO, transfusion-associated cardiac overload, again, very rare. Other allergic reactions, also very rare. Possible adverse events, again, very infrequent. So we concluded, and we expected this to be the case, this is a pretty safe product. The second thing that was embarked on, I'm going to spend some time on this, is a meta-analysis of the overall evidence space for convalescent plasma. And that's on the medRxiv server. It's not yet been published, it's in submission. And of course, on the medRxiv server, we updated. I'm going to give you my slides that I derived from it, not necessarily exactly the ones that are in the paper. So what kind of evidence do we have? We have basically 2 kinds of studies. One is treatment control studies, usually single hospital. You take the people you treated with convalescent plasma and you compare them to people you didn't treat. And many of these involve sophisticated multivariate, sophisticated matching schemes and multivariate results. Some are just plain old and simple, but we'll give you what we have. So in countries other than the US, we know of 6 studies. There have been 1 or 2 that have come out much more recently. And the pattern is very clear that in these studies, every one of them, the mortality is lower in the people who got convalescent plasma. Of course, biases, I'm completely aware of that. No question that these are all sorts of potential biases and components could enter here. It's interesting, though, that they operate at different levels of mortality from a study patient population, which nearly everybody died, Zheng in China, item 4, to a population where few of them died, also from China. So there's a lot of variation in the risk profile of people being treated with convalescent plasma. Overall, the estimate is there's about a 60% reduction in mortality with the use of convalescent plasma in these observational studies. The US studies are, I think, in some ways a bit more sophisticated, particularly the paper, the first one from Mount Sinai Hospital in New York, actually had very careful matching. And they almost everyone showed a reduction, very often significant. Rogers and Providence had the least effect, but still got a 20% reduction. The overall reduction is about 35%. And the important takeaway point here is that not so much that that we're sure that these are accurate, but you're getting study after study in which pretty much everybody gets a reduction in mortality with convalescent plasma. Now, randomized trials, the gold standard, unfortunately, the universe of randomized trials is very, very limited now. NIH did not invest in doing randomized trials of convalescent plasma, showed very little interest in that, unfortunately, in the beginning. Part of the reason I think the EAP was set up is because there weren't any trials going on, or very few. Eventually, around June or July, the NIH began to get interested in and began funding some randomized trials, but it was rather late. We've not had a single randomized trial of convalescent plasma published from the US, all these studies from overseas. The first one published was from Wuhan, showed a reduction in mortality, not significant, and it was restricted to individuals who were not ventilated at the time of treatment. If you took out the ventilated patients, there was a significant reduction in mortality. By the way, this was true of the Mount Sinai study as well. Definitely an effect in people who were unventilated at the time, not an effect in people who were ventilated. The two studies that were terminated early, actually all these studies were terminated early. China and the Spanish study ran out of patients. The epidemic was controlled locally. Again, both showed reductions. The Dutch study was terminated early for a peculiar reason. They said that they discovered that at baseline, a lot of their patients already had antibodies. A lot of us think that's not a really good reason because we're not quite sure what the effect of antibodies are. They stopped it even though they had a reduction, a halving of mortality that was almost exactly what was predicted from their initial estimates. But anyway, it is what it is. Rashid in Iraq also found an effect in a quasi-randomized trial. It wasn't perfectly randomized the way we'd like to. The one outlier, it's just been published in the British Medical Journal, but it's been available on the Medric server for quite some time, is Agarwal in India, and they found no effect. And it was the largest trial. Unfortunately, there are some, well, let me first say, first of all, although they found no effect on mortality, they did find an improvement in oxygenation levels, and I believe also in improvement in condition. But their big problem was they had only a small fraction of their donors had high antibody titers. They took their pool of donors from people who were not very ill, and it turns out that people who are not very ill with COVID don't produce as robust an antibody response as people who are very ill. And there may have been a problem that they didn't have an enriched enough antibody profile. The other studies you see, all four, did either some pre-testing to establish that the plasma was rich in antibodies, or after the fact they proved that. But the one exception to that was Agarwal in India. So the third study, after we reviewed, is the effect of the antibody levels in plasma. And I think this is the single most important study to emerge from this whole effort. And what it required doing was going back to the blood bank to retrieve remnant serum samples from transfused units, which are linked by a code, and to have them sent to Mayo for antibody testing. The reason remnant samples are kept is in case someone has an infection after a transfusion, you could go back and see, oh, was there some infectious agent we didn't clear out of the transfused plasma, unrecognized. And there was also the FDA did some separate testing of its own, and they sent they also got retrieved remnant serum samples and sent them to the Broad Institute in Massachusetts to test. At least 56 blood banks participated. The Mayo laboratories received more than 3,000 samples. FDA Broad got 4,300. Both groups used different antibody tests to determine the level of antibody in the plasma. Since we assume that the antibody is the active principle in the plasma, then we assume that the higher the antibody titer, the better the therapeutic response. And also, since antibody levels were unknown at the time of transfusion, The findings might be a little bit more difficult to confound than many things, because it was almost, I wouldn't say it was random allocation, but had some elements of a random process, a little bit like a natural experiment. So what did we find? Well, using the ortho IgG SARS-CoV-2 spike subunit 1 protein, in other words, a fairly standard IgG antibody test, we found lower mortality in recipients of high titer plasma, defined as the top 20th percentile in antibody titer, compared to the people who got low titer. And there was a dose response. The middle group had medium levels. We did a lot of multivariate testing, and the extent of difference was significant in some models and not in others, which is complicated. But there was a very powerful interaction noted in the data. If you looked at patients who got their plasma when they were on ventilators, they had essentially zero effect of mortality. You can see they're adjusted or unadjusted. But if you looked at the unventilated patients, people who got their plasma before they became very ill, the adjusted mortality was about 40% lower between high and low. And the adjustment factors in this particular analysis was early or late treatment in the course of the epidemic, age, race, obesity, pulmonary ventilation ratio, oxygen ratio in the inspired oxygen, lots of lung infiltrates, and the use of hydroxychloroquine, which was changing over time in the EAP database. In the early days, in April, just a little aside, 60% of all patients in the EAP database in April had been treated with hydroxychloroquine. In August, it was 3%. Commentary on medical decision-making about drugs. The FDA replicated this in using a different antibody test, and that's published on their website, a viral neutralization assay. They dichotomized as high and low. They didn't do the extremes. And as you can see, they replicated a lot of what we found. If you look at the relative reduction in everybody, it's 9%, not significant at 7 days. But if you look at non-intubated patients, non-ventilated patients, the reduction was 21%, and that's significant. And if you remove the elderly patients and people not treated early, you had a 44% reduction, and these are similar at 28 days, but a little lower. So the FDA, seeing both forms of data, which they analyzed very, very carefully, and we know that because we were working with them, sending data back and forth, were convinced that this is a good signal of effectiveness. And by the way, a small Israeli study also found that in their transfused patients, high antibody titer was associated with lower mortality. So these antibody findings combined with the safety data convinced the FDA to issue the emergency use authorization on August 23rd, and then the fun started because the politics came into it. First of all, in August, the White House began to show an interest in convalescent plasma. We know that the FDA Division of Biologics was very carefully analyzing EAP data, focusing especially on the antibody level information from both their own analyses and the Mayo Clinic analysis, which were very similar. And to issue an emergency use authorization, you have to have evidence of safety and evidence that the product might be effective. This is an emergency use authorization, extends only to hospitalized patients during the current state of emergency. It's a much lower standard than labeling. And this emergency use authorization did another thing. It required that all convalescent plasma issued be labeled as having high or low antibody. They set a threshold, and if you're above that, the blood bank would say high, below that low. They given a couple of months to work this into their systems. Then the New York Times reported that the NIH, represented by Drs. Fauci and Collins, were opposed to the issuance of the EUA, said we don't have a big randomized trial, it's wrong to do. And they also further reported that President Trump called Collins sometime in that week and said that convalescent plasma must be approved by Friday, August 21st. The Republican convention began the following Monday, the 24th. The actual EUA was issued on the 23rd. By the way, Collins would have been the wrong person to call because he doesn't make that call. He's not the Division of Biologics of the FDA, be that as it may. A lot of people assumption was made that this was because of White House pressure. And this is a very critical question because the Division of Biologics, who authorized plasma, is the agency who will approve a COVID vaccine. Now, we had been working with the FDA Division of Biologics and its director, Peter Marks, for some months, and we unanimously were convinced the decision to issue the emergency use authorization was based on sound science. And Arturo Casadevall and I authored 2 media pieces, the first in the Bloomberg News just after the FDA issued the EUA defending the decision as based on good science. And the second, nearly a month later, in the Wall Street Journal, this was Arturo's great idea, explaining why scientists sometimes disagree, why the FDA and the NIH might disagree on matters of scientific interpretation. So this was the first one. FDA made the right call on COVID plasma treatment. By the way, the headlines, of course, made up by the newspapers. And the second one, in the Wall Street Journal, a little debate on plasma is healthy for science. So we were trying to kind of give a little bit of an explanation to the world of why these decisions were made and why there might not be full agreement. We've heard, by the way, since that Dr. Collins has come around and agreed that the EUA is appropriate. I don't know that detail, but I've been told that. What about trials on the horizon? We still don't have a single US trial published on convalescent plasma. Right now, Lisa Ann Perovsky, who is part of our leadership team, she's at Einstein, directs the largest current US hospital trial of convalescent plasma. The sample size is now over 300. They had a first look at the data a while ago by the DSMB when it was about N equals 150, and they encouraged continuation of the trial. In other words, the results were not either damning or convincing. Take more data. Lisa Ann openly worries that in the early enrollment in April and May, now that we know that ventilated patients don't benefit from this or suspect they don't, may have been too sick to benefit from CP, and that may be a problem. Another member of our leadership group, Shmuel Shoham of Hopkins, is now directing a trial of uninfected people of high risk of exposure. In other words, for example, healthcare workers, and he also participates in another trial of outpatient treatment of mild to moderate illness. And we list all US trials of which we know on our website. Well, let me wrap up by saying, how could we all do this and still retain our day jobs? In my case, I don't know about the others, the answer is great collaborators and great research staff. And I'd like to thank a lot of people. The first group is my co-principal investigators in our ECHO project, which is a big, hairy NIH project, which takes a lot of work. Jean and I are the co-principal investigators at MSU. Doug Gruden, a neurotoxicologist, is at Wayne State. Patty McCain of the Michigan Department of Health and Human Services represents our health department subcontractors. Mike Elliott, great biostatistician at U of M, and Charlie Barone, a wonderful pediatrician at Henry Ford, are our team, and they have stepped up to the plate fully. And more than that, we have a fantastic study office. Those of you on the 6th floor now, at some point, you'll eventually get back into the building. Wander down to the 2nd floor, where you'll see our offices, and you'll see this great, great team of wonderful people. Alexa is our day-to-day project manager. She takes care of every single detail and talks to NIH and the various study centers. Tracy Thompson takes care of communications with our patients and all our involvement with data requests and keeping our scientists involved and setting up meetings with them. Brianna, who, as I've said, I've plundered to use in our COVID work, convalescent plasma work, is in charge of follow-up. And Teng Fei is our data manager. Someone who's also given us some time for the convalescent plasma project. And then we have Kirsten and Kylie, Shelley and Bree and Janelle, who do a lot of interviewing and data managing and obtaining samples and writing to participants to please send their babies shed teeth in, and so on and so forth. A remarkable amount of work done by some wonderful people, and that has allowed me to take a little bit of a break from that. So, conclusions. even absence a large randomized trial, it's hard not to see powerful evidence from a variety of sources of convalescent plasma efficacy in reducing mortality, and of course in doing other things as well. I think the data showing the dose-response relationship of antibody levels, which were unknown at the time of treatment, is very hard to explain away. It's clear that early treatment is better than waiting until disease is more severe and complications have ensued. If I were to get COVID-19, I'd want high-titer convalescent plasma as soon as possible. Let me be frank. And as for precision medicine, our starting place, frankly, we still await a measurable therapeutic or preventive advance in COVID, or frankly, in any other disease from precision medicine approaches. And let me add, as we watch the progress of the epidemic, and its progress is clearly dependent on failure to wear masks and to socially distance, and reluctance to give up, even temporarily, parties and other mass gatherings. I return to Mike Joyner's words from 2015 that I quoted in the first slide. We'd be better off directing resources to better understanding what it takes to solve messy problems about how humans behave as individuals and in groups. Thank you very much. Happy to take questions.
Thank you very much, Nigel. I don't know if you can hear any of our clapping, but
I can't, that's okay.
I'm wondering if I could start off with a question, which is about after this wonderful tour of how you have approached this exploration of the efficacy of convalescent plasma. If you could tell us about some of the impediments, including cost, for this treatment.
Well, that's a good point. You know, the interesting thing about plasma, we recognize this early, is compared to pharmaceutical products, there's no big pharma behind it. There is no, it's just patient to patient, and the cost is minimal. It's the cost of doing the plasmapheresis, basically, and purchasing the unit from the blood bank. Remember, the blood bank world, which is where convalescent plasma has to come from, is operated on a not-for-profit basis. People are not paid to donate blood. It's a donation. It's the gift of life, as they like to say. So blood and plasma are donated products. So one of the big advantages we thought was this is not going to be costly. It's going to be a little difficult sometimes to arrange because it's not like taking a medicine off a shelf, but you won't have any large profit behind it. And I think the costs in hospitals are in a few $100s level. And you know, the interesting thing is the product can be obtained from people repeatedly. I mean, Mona Hanatisha, some of you know Mona in Flint, got COVID in a trip to England in March or April, has given convalescent plasma at least 3 times, to my knowledge, you know? And other people have given more. So it's not a very costly intervention. We think that the cost, we think that remdesivir, which is a pretty effective drug, a single treatment is about $6,000. We don't know what the convalescent plasma, the immune globulin, the monoclonals are going to cost. The polyclonals are perhaps not going to cost too much because there's a decision been made to make them generic and non-profit. But the monoclonals by Regeneron and Lilly, who knows? So convalescent plasma has the advantage of being cheap too.
Good to hear. Good to hear this. We have a question in the chat.
Okay.
From Felicia Wu. Felicia.
Oh, hi, Felicia. How are you? Can you unmute her so she can say her question? Is that feasible?
Oh, hello, Nigel. Hello, Madeline.
Hi.
Hi.
How are you?
Oh, doing well, thank you. Wonderful talk, Nigel.
Thank you.
My question had to do actually with your last one of your last statements, which I think you've convinced many of us now, which is that if we got COVID-19, we would want to get high titer convalescent plasma as soon as possible. Then would you recommend that FDA approves it not just for inpatient settings, but also for outpatient settings? What is the barrier to doing that, and is supply a problem?
You know, that's an interesting question. I think the tension has been all along between treatment and doing randomized trials. And we've got a lot of criticism for the AP. They're saying this interferes with doing trials. And as you've seen, the leadership group is doing trials as well at Hopkins and at Einstein. So it can go in parallel. The argument has been made that outpatients are not that desperately ill, and we have the luxury perhaps of completing the trials that are being done now. The Hopkins outpatient trial in mildly ill people, and I think there are some other outpatient trials going on nationally. So I think given that all the data we have is really from inpatients, I think it's all right to wait a little bit and see if we get some trial findings first, because it may work differently in outpatients, you know. So
okay, thank you.
Do we have any other questions out there?
Madeline, if we have time for another question, this is Jim. I'd love to ask one.
Hey, Jim. Sure. Love to hear one from you, Jim.
It was a great talk, Nigel. I really appreciate it.
Thank you.
And it's wonderful work. I want to zero in on the last sentence of your talk and the quotation about understanding the messy world and decisions people make and the ways humans and society behaves. Can you help us reflect on how it happens that in our epidemiology curriculum, we don't really have much in the way of required coursework on people making behavioral choices, whether as individuals wearing a mask, social distancing, or collectively as individuals, say in a church congregation or something like that?
You know, it's a wonderful question, Jim. And, you know, I hope the next generation of epidemiologists, the younger people in the audience, will reflect on it and maybe think of ways to introduce that into the curricula they will teach in the future. Behavior change is at the heart of everything. I mean, we've been saying this mantra for decades in heart disease, especially, you know, eating well, checking your blood pressure, screening for cancer, all sorts of health behaviors, not smoking. It's funny how in an epidemic, health behaviors suddenly become massive, you know, absolutely massive. You might think in an epidemic, well, people are going to get it. No, it's crucial. And you see every surge we see is a function of behavior, of decisions made, and of models set forth at the highest levels or not set forth, or set forth the wrong models. And we hope that we can induce behavior, get people to understand the need for behaving in a sensible way to protect themselves and to protect others. But I agree with you, it's a very, very important, massive topic in our field and in public health in general.
Thanks a lot. Stay safe.
Yeah, you too. I saw a question from someone in the chat. Now the chat has come up. Why is NIH, Todd, reluctant to fund RCTs? Let me yeah, and I'll answer Matt too, my colleague and critic. Let's first start with Todd's question. Why? Actually, the NIH is not reluctant to fund RCTs. It's just that they, I think, again, if you start to think about it, maybe we were drawn to, the anti-precision medicine group was drawn to convalescent plasma because it was simple, not high tech, historically proven, and maybe there's a part of science that doesn't like that. They want high tech, fancy. Why do you think the president got convalescent antibody, got monoclonals, the least studied form? I mean, is that the responsible thing to do? Wouldn't you do most studied form like convalescent plasma instead of the least studied form? You know, but it's high tech, it's jazzy, it's made in the laboratory. And I think that prejudice influences a lot, unfortunately. And So convalescent plasma didn't seem to. We heard discussions in the early going. NIH, FDA. Oh, we'll have a hyperimmune globulin product soon. We will have monoclonals any day now. But they were saying they were expecting it in July. It's now October. You know, these things take time. But convalescent plasma didn't take time. And it's unfortunate that the NIH did only later it came to its support. Now it's supporting Leanne Perovsky, a big group at Vanderbilt, which has gotten a lot of money, not so many patients enrolled yet. I just think it wasn't jazzy and sexy, you know, convalescent plasma. Too old-fashioned, too blah, you know, that's been done before, except it works. I think it may work. Now, as to Matt, without benefit of doing RCTs, how can you identify which subset of patients will benefit from treatment using the observational data alone? We can't for sure, but it's this question, this pointed question of we know what the rules are for weighing evidence in general. What are the rules for weighing evidence in an epidemic situation? Without the benefit, so we should do nothing while we wait for the RCTs to come in. We've treated 85,000 people with convalescent plasma, and we have a suggestion from 2 different antibody tests that people who got high antibody plasma survive better than people who didn't get high antibody plasma. It's, you know, could that be confounded? We've looked at every possible set of confounders you could imagine. We can't get rid of the effect, okay? Especially, and certainly in the unventilated patients. Given that state of knowledge, and someone was hospitalized, would you say, I'm sorry, we have to wait until the trials are done, my dear? I'm sorry, we can't treat you. I mean, you know, this is the dilemma we face in medicine, you know? That's my argument. You know, we all wish we had randomized trials, but we don't have them. There, you know, it may be that in a few weeks from now, we'll have randomized trials out. Now, you either tell us Paneth led you down the garden path, there's nothing to it, or they will say, it looks pretty good. But there's a whole lot of data out there that is very supportive of effectiveness, and it's really pretty hard to put behind you. The exact threshold, Joey, is very difficult to determine because it seems to be a continuum, and there are so many different antibody tests, and none of us know which is the key one. Is it neutralizing antibody? Is it generalized IgG? Is it antibody to the spike protein? Is it antibody to something else? So we have to just base our best guess on what we have. The FDA set a specific threshold level using ortho IgG, even though that wasn't the test that they published on, above a level and below a level. I could not try to defend that, but they had to make a pragmatic decision to draw a line. I can't remember the exact number, but the FDA website has it. And now, you know, you're supposed to get, if you're going to get transfusion, you're supposed to get a high, you'll probably get one with high, a high amount of antibody, or if it's low antibody, you might get 2 or 3 units, or it might be sent to the plasma fractionators to make hyperimmune globulins. Let me see, what's the next one? No, there was one before Bradley. I think I saw one that I missed. Oh, Gwen. Hi, Gwen. We did not look at obese versus non-obese patients treated with convalescent plasma. My observation of the data I've seen so far is obesity is not such a huge risk factor. It's a moderate risk factor. Age is much more important. Pre-existing underlying cardiac disease is much more important. Underlying serious pulmonary disease. It's a bit of a modest factor, and we'll be looking at that because we have this great database. But I don't know the answer yet. Is anybody who has COVID recruited for getting plasma? Only people with COVID positive tests and symptoms. This is from Bradley Allen Riva. And if asymptomatic people donating, okay. We get the impression, it's not been studied systematically, that the asymptomatic or mildly symptomatic have lower antibody titers. And but we haven't said, no, don't donate, because you could still use that. First of all, you can use that plasma for the ordinary plasma that's used in hospitals. Secondly, it could be sent to plasma fractionators to extract such antibodies as there, and mixed in with that of many other people, you could contribute to the product. And thirdly, it might be able to be given, you know, with multiple doses. So but clearly, but they're active, but they're very active patient groups supporting. In fact, one of the most remarkable stories of all is how certain individuals have made it their mission in life to get donations of convalescent plasma. And if you look on our website, you'll see a profile of Chaim Leibovitz, a New Yorker in the Orthodox Jewish community, who has been unbelievably effective at getting literally thousands of people to donate plasma. The first community hit hard were Orthodox Jews in New York, and they stepped up to the plate. They started giving plasma like crazy, and that's why New York was the epicenter of convalescent plasma treatment for a while. Mount Sinai and Montefiore and a number of other New York centers. And he flew to Florida and started to encourage Floridians to give. So it's quite a remarkable story. And there's a group called The Fight is in Us, a patient advocacy group. They're really quite wonderful. A lot of good things have come up. Oh, Felicia, Bradford Hill. Oh, I love Bradford Hill criteria. As well as regular. So yes, dose response, mechanism of action. This makes an eminent sense, mechanism of action. Consistency of results across many studies, you know. I think we're doing pretty darn well in Bradford Hill, Felicia. I hope you agree. And Brianna gives us our webpage, the link to the webpage. Thank you. Raed, hey Raed. Are you optimistic when looking at the near future? And do you think this winter we will lean towards herd immunity? No. Right now, what is the best estimate of total immunity in the country? How many people do you think have naturally occurring antibodies? Maybe it's 10%. On a good day, 10%. Anybody has an estimate?
20, 25, maybe.
Oh, maybe in epicenters like New York City, the whole country. Do you know how many people would have had to be infected? And again, remembering that mild infections may not give you such great antibody responses. I don't think we're anywhere near herd immunity. You've got to wait for a vaccine to get herd immunity. And I think we're going to have a lot more cases unless people change their behavior substantially. And those cases, even if it's young people getting them initially, and so now in the first wave of September, October, we're not seeing many hospitalizations and deaths. Eventually it moves around. It gets to the older susceptibles and the people. It's just people can't avoid communicating with people. And unfortunately, I predict that we'll have more deaths as the CDC does. We're already up to 220,000. It's going to go higher, a lot higher before we're done. Sorry to tell you that. Right? Yeah, I think Matt, 6 to 8%. I'd accept that, Matt, as how many are immune now. 90% of us are quite susceptible. Barrett, from the patients who received treatment, can you speak to any difference in patients who requested accepted and those who did not get? Did this change after the White House announcement? There's a lot of interest in trying to study determinants of who got and who didn't get. Our data, unfortunately, is all people who got, so we don't really have much discrimination there. The place to look would be the observational studies. They're not generally, it's not clear that in the observational study the risk profiles are dramatically different between people. Sometimes you wonder about drug use. You know, if someone went the remdesivir route, did they not go the convalescent plasma route? If they went the hydroxychloroquine route, did they not go? So it's a very tricky business. It's always hard to pick up a signal from observational data of treatment. But again, we're going to look at that. As to did the White House encourage the use of CP? I don't know what the net effect of White House announcements are today. Do they encourage or do they discourage? Search me. I don't really know. Honestly, don't know. Okay, I think I've answered all the questions. Brianna has helpfully put in The Fight is in Us, which is a very nice group of people, nice website. You can see their work.